slowly so that everyone can understand. During pregnancy, we can come across cardiac disease, and this is a high risk pregnancy. The symptoms which indicate that the patient can have a cardiac disease are usually shortness of breath or dyspnea, palpitations, syncopal attacks, chest pain, or feeling of fatigue. We do have to rule out anemia first of all, and if the patient is anemic, we have to correct her anemia first because that can also give rise to same kind of symptoms. And then we have to diagnose cardiac disease by doing specific portions in clinical history, examination, and investigations, out of which echocardiography or cardiac imaging is the most important investigation. So, if we talk about the introduction, then this is the leading cause of maternal death in the developed world, even in the developed world. So, what to think about countries like us where we are not reaching the women when they are pregnant at all levels, and especially in the rural, far-flung areas. Incidence of cardiac disease in pregnancy is less than 1%. Women with risk factors of adverse cardiac events should be managed and counseled by a multidisciplinary team. So only an obstetrician or a physician cannot help. It has to be a combined clinic. We call it an MTD or multidisciplinary team approach. And the counseling should ideally start before the pregnancy. If the patient is known to have a cardiac disease, she should undergo a pre-pregnancy counseling and then she should opt for pregnancy. We will talk about certain physiological adaptations. In pregnancy, the plasma volume increases. This leads to physiological anemia of pregnancy. The patient is already having a lot of plasma volume, so the burden on heart is already more. So if the heart is already diseased, this would be more pronounced. There is profound fall in systemic vascular resistance. Increased cardiac output, which is achieved by increase in the stroke volume and increase in the resting heart rate. So the palpitations and overall high volume pulse is part of pregnancy as a physiological adaptation. So we have to have an extra suspicion when we are suspecting cardiac disease in pregnancy. By the end of second trimester, the plasma volume has risen by 30 to 50%. That's why the symptoms, they start appearing from 24 to 26 weeks and they peak around 32 weeks because the volume of plasma is there and it is very high at that time. So if the patient has already got a cardiac disease, the symptoms would be very high during the late second trimester. Similarly, during labor, there is a high increase in cardiac output, especially during the first stage, and 50% during the second stage when the patient is actively pushing. The burden on the heart is too much at that time. And just after childbirth, the placenta is delivered, the uterus contracts, almost 1 liter of blood is returned back to the circulation, which can cause sudden pulmonary edema in these patients. The intrathoracic and cardiac blood volume rises. Cardiac output increases by 60 to 80%. The women with cardiovascular compromise are therefore more at risk of pulmonary edema during second stage of labor and in immediate postpartum period. Please remember this. During second stage of labor and immediate postpartum, when the uterus contracts, a lot of volume returns back to the system. The woman is at high risk of pulmonary edema and heart failure at that time. And all these changes revert quite rapidly during the first week and more slowly over the following 6 weeks in pregnancy. So, the examination findings during pregnancy, the normal findings are loud first heart sound, exaggerated splitting of the second heart sound, and a physiological third heart sound may be visible. A systolic ejection murmur can be heard. Diastolic murmurs are always pathological. A systolic murmur can be heard in anemia and also in normal pregnancy if the patient is anemic, but diastolic murmurs are always pathological. Ectopic beats can also occur in pregnancy, but arrhythmias and irregular pulse is always pathological. Ankle swelling is also common in pregnancy in a physiological state, but if it is accompanied by hypertension and facial edema, then we must consider preeclampsia as well in these patients. So talking about the cardiac investigations, if we see the ECG, there is some left shift of the axis towards the left side. In small Q waves and T waves inversion, inferior and lateral leads can occur. Troponin is not affected by pregnancy. Therefore, if we suspect myocardial infarction, then the troponin test is always the gold standard because the T wave and Q wave changes can occur in normal pregnancy as well. Similarly, echocardiogram is the investigation of choice to exclude the structural heart disease in pregnancy. General considerations in pregnant women with heart disease. The outcome and safety of pregnancy is depending on the presence and severity of pulmonary hypertension. If due to any reason there is pulmonary hypertension, the prognosis is always bad. The presence of cyanosis also indicates that there is some left to right shunting now and mixing of the blood, so the cyanosis is also a bad sign. Even in congenital heart disease, when the cyanosis is already there, then worsening of cyanosis is more pathognomonic of the disease worsening. Hemodynamic significance of the lesion, how much the lesion is severe, what is the gradient of pressures across that lesion is also important to know what kind of behavior would be seen in these cardiac diseases. And functional class is determined by the level of activity which the patient can undertake, which leads to dyspnea. We will see the details of NYHA classification, which categorizes the cardiac disease into levels of severity into 4 classes. This is called New York Heart Association classification, also called NYHA or NIHA classification. Women with pre-existing cardiac disease usually tolerate pregnancy well if they are asymptomatic and they are in class 1 or 2. But those who are in class 3 or 4, they cannot tolerate pregnancy well. There are certain conditions in which pregnancy is totally contraindicated. Let's see what are those. These are pulmonary artery hypertension, severe systemic ventricular dysfunction when the ejection fraction is less than 30%, previous peripartum cardiomyopathy, severe mitral stenosis, severe symptomatic aortic stenosis, Marfan syndrome with aortic dilatation of more than 45 mm, aortic dilatation of more than 50 mm in aortic disease, and native severe coarctation of aorta. Again, please note down the point. All the regurgitant lesions, they behave well in pregnancy, but all the stenosis lesions, they become more severe during pregnancy. Let's see the New York Heart Association classification. Class 1 and 2 are called mild, 3 is called moderate, and 4 is called severe. Mild is when the patient has no limitation of physical activity. If you ask her what were you doing before pregnancy, she would say, I was rooming 2 rooms, I was making 6 chapatis, I was making salan twice a day, and I have nothing, no dyspnea when I do this much work. But when I cook 10 chapatis or if I room 4 rooms, then I get breathless. So there is no limitation on regular activity, the one which she was already doing. But beyond that activity, she will get breathless. On class 2, the physical activity which she was performing is causing her problem now. She is comfortable at rest, but the regular activity will cause the problem. And in class 3, there is marked limitation of physical activity. She is still comfortable at rest, but less moderate than ordinary activity causes fatigue, palpitations, and dyspnea. And in class 4, she is even dyspneic at rest and sometimes even on lying down. So this is how we classify these diseases. There are certain risk markers for maternal cardiac events during pregnancy. We call them Toronto risk markers for maternal cardiac events. These are prior episode of heart failure during pregnancy, New York Heart Association class more than 2 along with cyanosis or only cyanosis, left heart obstruction, ejection fraction less than 40%, and if there is no predictor out of all these 4, then the risk of cardiac event is less than 5%. If one predictor out of these four is present, then the risk of cardiac event in pregnancy is 37%. If more than one predictor out of these is present, the risk of cardiac event is 75%. So if we see what happens in congenital heart disease, the various kinds of congenital heart disease are aortic, atrial septal defects, ventricular septal defects, tetralogy of Fallot. And if these patients are acyanotic, they can tolerate pregnancy well. In developed countries, it is usually the congenital heart disease which is more common in pregnancy. But in developing countries, it is the valvular heart disease because of rheumatic fever, which is still common in our areas, and cardiomyopathy because of multiparity. So in developing nations, in poorer nations, the valvular heart disease and cardiomyopathies because of multiparity and rheumatic heart disease are more common. And in developed nations, it is congenital heart disease because they don't have multiparity, they don't have anemia, they don't have preeclampsia, they diagnose it earlier. And these women are usually suffering with congenital heart disease in developing nations, in developed nations. So women with congenital heart disease are at increased risk of having a baby with congenital heart disease. The risk is around 4 to 10%. So an echocardiography of the fetus done around 18 to 20 weeks, especially around 22 to 24 weeks, is very, very important to see any congenital heart disease in the baby as well, and to be ready to treat these babies when they are born, so that they are taken care of right once they are born in a proper way, in a multidisciplinary team approach. If it now we are talking about the congenital heart diseases one by one. If it is ASD, atrial septal defect, this is the commonest congenital cardiac defect in adults. And mitral regurgitation is caused by the mitral leaflet prolapse. It develops in up to 15% of patients who have uncorrected atrial septal defect. Usually they tolerate the pregnancy well. But acute blood loss, if it occurs, that can cause a problem. And if they rest well, they don't get anemic, there is no fever, infection is prevented during pregnancy, then they tolerate pregnancy well. Let me give you some general principles of managing a pregnancy with cardiac disease. These patients should not get anemic. If they are anemic, any cardiac disease in pregnancy, we should treat them. The anemia should be treated. Similarly, any infection like fever, UTI, vaginal infections, general viral infections, malaria, because it causes tachycardia. Fever causes tachycardia. This causes extra burden on the heart. So any infection should be treated in time. Similarly, thyroid disorders, because it causes tachycardia, they should be treated. So if any heart disease has got these problems, they should be dealt very, very rapidly. Otherwise, the condition of the woman can deteriorate rapidly. Coming to the second congenital heart disease, which is VSD and patent ductus arteriosus, these defects are also well tolerated in pregnancy, unless the defect is very large and there is already pulmonary hypertension. If there is no pulmonary hypertension, the left atrium is not that big, then aortic septal, atrial and ventricular septal defect don't cause a lot of problem during pregnancy except for mild breathlessness and palpitations, provided the woman is prevented from anemia and prevented from hypertension and any infection. Pulmonary stenosis, all stenotic lesions I have told you can cause problem. Pulmonary stenosis does not usually give rise to symptoms during pregnancy, but if it is severe and it causes right ventricular failure, then it can cause problem. And in those conditions, pulmonary valvotomy by angiography is done, in which we open up the balloon and the valve gets open up and dilated and the stenosis is taken care of. This is done in early second trimester. Once the patient is 22 to 24 weeks, then the size of the uterus is so big that these procedures cannot be done. Aortic stenosis is a disease which scares us all. This causes a lot of problems if it is present in pregnancy. All valvular lesions, if they are already corrected, the patient will behave well. But if the valve is still diseased, then the condition during pregnancy can worsen. The ECG with aortic stenosis can cause left ventricular hypertrophy. And the significant obstruction, if the valve area is less than 1 centimeter, then the pressure gradient across the valve is so high, this can cause a lot of problems. So angina, dyspnea on resting, tachycardia, should be admitted to hospital if she has aortic stenosis and she develops all this. We usually give beta-adrenergic blockers to prevent angina and to take care of the dyspnea. If it is very severe, patient is not in advanced pregnancy, then again aortic valvotomy through angiography can be done. Similarly, coarctation of aorta, if it results in aneurysm formation, then the risk of dissection during pregnancy, dissection of aorta, rises a lot. And coarctation of aorta can be accompanied by aneurysm in the aorta. If there is coarctation and aneurysm, the risk of dissection of aorta increases. Hypertension in coarctation of aorta should be aggressively treated. Normal delivery is usually possible through, although severe coarctation would indicate a shortened second stage. In any kind of cardiac disease, we encourage vaginal delivery if the patient can tolerate and there is no other obstetric indication. We wish them to undergo vaginal birth. But for shortening the second stage, we must apply instruments like vacuum and forceps. Marfan syndrome is in which commonly mitral valve gets prolapsed. Pregnancy increases the risk of aortic rupture in this. Marfan syndrome, is an autoimmune connective tissue disorder in which the risk of connective tissue disorder and aortic dissection is very, very high. So, cyanotic heart disease like Eisenmenger. Eisenmenger is a condition when there is left to right shunt. Usually, there is right to left shunt, but from left to right shunt is the usual condition. But when there is right to left shunt, then Eisenmenger develops, which is very, very pathological and it can cause problems during pregnancy. So even in tetralogy of Fellows, there is obstruction of the large subaortic ventricular septal defect. It's four things, which occur. The pregnancy can be tolerated well, but fetal growth is poor and the miscarriage rate is high. They have a lot of red cells in their body because they are in constant hypoxemia. So in these conditions, we usually need to give them either aspirin or low molecular weight heparin. Otherwise, the fetal growth restriction can occur. Modern management of pulmonary hypertension includes drugs like sildenafil and bosentan. They reduce pulmonary pressure and this can cause better pregnancy tolerance. Otherwise, if it is intolerable, then therapeutically termination of pregnancy can be indicated for saving maternal life. Now let's talk about acquired valve diseases. But before I go to valve diseases, I wish that you people understand the general principles of managing any cardiac disease in pregnancy. As I have already told, if the patient has uh, tachycardia, she has palpitations, she has syncopal attacks, and she is not anemic, we should suspect a cardiac disease, and we should take complete history, examination, and assess what kind of NYHA class she is in, and then any risk factor like anemia, hypertension, infection, thyroid should be treated. And then during pregnancy, we need a multidisciplinary team approach. And once she is in labor, she has to be propped up. There has to be oxygen given intermittently to the patient. The fluid restriction should be taken care of. We should not just keep on giving them fluids. And during childbirth, in the second stage, we must shorten the second stage by applying instrument that is forceps or vacuum. Once the baby is delivered, I have just told you, 1 liter of blood after contraction of the uterus can be given to the system and the patient can undergo pulmonary edema. To save that, we have to watch that she has passed enough urine, she is propped up, and if required, we can give a diuretic just after delivery like Lasix, 20 milligram, slow intravenous, so that she diureses and this extra volume of the fluid which is returning to the system does not causes pulmonary edema. We have to give her good analgesia during labor, like a tramadol infusion or a paracetamol infusion. The ideal is epidural analgesia, but in our setups we can't give. So giving them other analgesic options like tramadol or paracetamol can be helpful. Similarly, once the baby is born, the baby should be completely evaluated by a pediatrician for any congenital heart disease any growth restriction, uh, or any other problems due to heart disease. And in certain complex conditions like cyanotic heart diseases and congenital heart diseases, during labor we have to give them infective endocarditis prophylaxis. So now coming to the valve diseases. The valve diseases can be mitral valve prolapse. This is a very common condition. It does not cause a lot of problems during pregnancy. But mitral stenosis is quite common, and it is very, very problematic during pregnancy. I've already told you all stenotic lesions like mitral stenosis and aortic stenosis can cause problems as compared to mitral regurgitation or aortic regurgitation or tricuspid regurgitation. Because the systemic vascular resistance is low, the regurgitant lesions become better during pregnancy, and the stenotic lesions become worse during pregnancy. So tachycardia, pain during labor, anxiety, any infection can cause arrhythmias, and these can cause worsening of the mitral stenosis. Commonest complication in mitral stenosis cases is pulmonary edema. The risks are increased if the valve area is less than 1 centimeter. And the diagnosis is confirmed by examination in which we hear the mid-diastolic murmur, and then it can be confirmed by echocardiography. We usually give them beta blockers, and we can take care of their pain during childbirth. And I have already told you intravenous furosemide or Lasix injection can be given just after birth. Digoxin is only given in such cases when there is atrial fibrillation. Women with mitral stenosis should avoid the supine position and lithotomy positions. Any cardiac patient during labor should be propped up. Oxygen should be given intermittently. Oxygen fluid should be taken care of. And after delivery, during pushing, we have to shorten the second stage. And after delivery, we have to take care that they don't get into pulmonary edema. Regurgitant valve lesions, I already told you, are better tolerated during pregnancy as compared to stenosis. If the patient, due to any reason, has undergone a valve replacement, which is called mechanical heart valves, because these are cheaper and they are usually available. And in our setups, usually the patients, when their valves are changed before pregnancy, it is the mechanical heart valve. And during pregnancy, the mechanical heart valve, because of extra thrombotic conditions in pregnancy, can get thrombosed. These patients are already on anticoagulants. Those who have mechanical heart valves are on anticoagulation by warfarin. But during pregnancy, it is said that warfarin can cause embryopathy. So as soon as the patient is confirmed her pregnancy, we change them to heparin. We stop warfarin and we change them to heparin. And once the organogenesis is complete, that is around 16 to 20 weeks, then patient starts on warfarin again. And once she is in advanced labor or she is reaching term, that is 34 to 36 weeks, then we again stop warfarin and we switch them to heparin, because warfarin has a longer half-life and heparin has a shorter half-life. So if she is on warfarin, she might bleed a lot because of excessive dose. And heparin has a shorter half-life, and heparin has an antidote in the form of protamine sulfate. So we can switch to heparin again near term, that is 36 weeks. So in early pregnancy during organogenesis, we switch to heparin to prevent embryopathy, and in later part of pregnancy, we shift from warfarin to heparin to prevent risk of hemorrhage. The fetal risk from warfarin is dose dependent. Fortunately, usually women need 5 milligram daily. And at this dose, the risk of teratogenicity is very, very low. Talking about the heparins in pregnancy, we usually give low molecular weight heparin, but they are expensive and not available very frequently. But now they are quite commonly available by the name of Calexane injection or clotless injection. This is low molecular weight heparin. It does not causes, it has a better safety profile. It does not causes platelet deficiency like unfractionated heparin or high molecular weight heparin. and it does not need close monitoring. If it is monitored, we monitor it by anti-10A levels. There are various clotting factors on which the heparins act. The low molecular weight heparin acts on anti the factor 10A. So if we need to monitor the response of low molecular weight heparin, then we monitor it with anti-10A levels. There are three basic options of anticoagulation management. Continue warfarin throughout pregnancy, stopping only at the time of delivery. Replace the warfarin with high dose or low molecular weight heparin 6 to 12 weeks gestation to avoid embryopathy, and then continue till she is near term. Or use high dose low molecular weight heparin throughout pregnancy, but it is expensive and it needs an injection every day. The risk of thrombosis is less with the new bileaflet valves called carbomedics. So the risk of thrombosis with newer valves is lesser, and the drugs are now coming up like low molecular weight heparin. So the risk of thrombosis with mechanical valves during pregnancy can be managed well by combined approach of an obstetrician and a cardiologist. Peripartum cardiomyopathy is another condition. So up till now we have covered congenital heart disease, we have covered valvular heart disease, we have covered if the patient has a mechanical valve, and we have done the general considerations of pregnancy and childbirth. And now we are touching the other disease, which is cardiomyopathy. During pregnancy, cardiac failure can develop secondary to left ventricular systolic dysfunction. The women who are at higher risk are those who have multiple pregnancy, who are multiparous, they are increased in age, they are Afro-Caribbean in race, or they have hypertension. Echocardiography shows a huge left ventricle which is not moving well. It is just fluttering. So we can diagnose it by doing the echocardiography in such patients. The diagnosis should be suspected in the peripartum patient with breathlessness, tachycardia, and signs of heart failure. Sometimes we diagnose it once the patient is delivered. A grand multipara has delivered. She is getting very breathless after pregnancy is over. Her anemia is corrected. There is no point of her breathlessness. She is not asthmatic. Then what is the reason? Then we get echocardiography done and we find out that she has pulmonary peripartum cardiomyopathy. These women usually are managed by cardiologist and obstetrician, and they are put to cardiac modulating agents and also on diuretics. If they are undergone X-ray, it shows a large heart with pulmonary congestion. Management includes use of oxygen, diuretics, vasodilators, and angiotensin converting enzyme inhibitors in the postpartum period. Thromboprophylaxis is also needed if the valve ventricle is very much large. Sometimes we need beta-adrenergic blocking drugs, but only if there is tachycardia, and it does not settle with diuretics. About 50% of women make a spontaneous and full recovery. The patient should remain on an ACE inhibitor for as long as the left ventricular function remains abnormal. Those whose LV function and size do not return to normal within 6 months are at significant risk of worsening heart failure and death and recurrent peripartum cardiomyopathy in the next pregnancy. So once they have diagnosed in peripartum cardiomyopathy, they have to be very careful to embark upon the next pregnancy, and they should undergo a complete evaluation if they plan another pregnancy. It's better to avoid it. Endocarditis prophylaxis is only given in rare pregnancy conditions like cyanotic heart disease, if there is an emergency valve replacement, if there is a valvotomy done. Otherwise, we usually nowadays don't give antibiotics or endocarditis prophylaxis. So during childbirth, previously it was recommended, but now it is not recommended unless there is a cyanotic or a complex heart disease. And the regime used is amoxicillin 2 grams IV plus gentamicin 120 milligram IV at the onset of labor or ruptured membranes or prior to cesarean section. For women who are allergic to penicillin, vancomycin 1 gram IV may be used for infective endocarditis prophylaxis. This is all from my end. Any questions you can write in the chat box or you can ask me.
Assalamu alaikum, ma'am.
Assalamu alaikum.
First of all, thank you so much for coming and joining us, and thank you so much for presenting this wonderful lecture.
Adia, was it useful? I was
Eh,
trying to be very slow. And I was trying to